Good morning, students. My name is Julia Withnell, and I'm a registered respiratory therapist. I work at Cox Monett, and I'm just going to give a little talk about what is respiratory therapy, what a respiratory therapist would do, and then we'll go over some equipment. You guys can see some of what we work with on a daily basis. I graduated from Virginia respiratory program in 1999 with an associate's in applied science and a major in respiratory therapy. After getting my degree, I did have to sit for a credential exam, and after that exam and passing that, I got my RRT, which is Registered Respiratory Therapist. I really have been blessed to work in a variety of areas in my career. I started out, my first job was at a children's hospital, and the name of that hospital was Children's Hospital of the King's Daughters in Norfolk, Virginia. I worked there for probably about 7 or 8 years, and I have to say, out of everything I've done in my career, that was definitely my favorite job that I had. I felt like I got to be a kid, because that's basically what you had to do when you're treating kids, is act like a kid. So how fun is that? You don't have to act like an adult. In that hospital, I worked in a long-term vent unit, and the patients that we would get in there are the NICU babies, where they couldn't wean off of a ventilator and go home. They had to have a much longer stay on the ventilator, so we would take care of those babies in that unit. I also worked in NICU. I got to do that, and I must say, working in the NICU, you really see the miracle of life. We're saving little babies outside of the womb. The youngest that we were able to really make a difference in their life was a 23-week neonate. And then lastly, I ended with the pulmonary clinic. And in the pulmonary clinic, we would see a lot of children with asthma. We took care of a lot of chronic lung issues, again, corresponding with, say, a NICU stay on a ventilator. And our cystic fibrosis population. We did have quite a population there in Virginia that we would see every week, and I would do pulmonary function tests on them. Then I started working in home care, and I must say that's another neat experience. You're going into everybody's homes. I would travel. In our home care area, I could actually drive probably 2 hours to go set up equipment. So we were all over that Hampton Roads area. And in home care, respiratory is in charge of setting up oxygen equipment. We set up CPAP and BiPAP machines, and that's for our sleep apnea patients. And if you don't know anything about sleep apnea, that is something that you have during sleep, whether it be the shape of your airway, your body size, which could be overweight or not overweight, your airway blocks off while you're sleeping. And the way CPAP will work is it pushes air in. You sleep with a mask or a nose piece, and that pressure keeps that airway open so you get a good sleep, which is very important. I know right now you guys probably don't get a lot of sleep, but when you get out of high school, sleep's important. We also set up home ventilators. We do have people that have to stay on the ventilator all the time, and they do get to go home if they have family that are willing to take on that responsibility. So we would train family and get that patient home on a ventilator. Currently, living here in Missouri, I work at Cox Monett Hospital. And areas that we cover in the hospital, we're all over. So all 3 floors. We work in the ER. We work on the 2nd floor in Med-Surg, and we're also up in the OB. So what I love about my job, number one, is the time that I get to spend with my patients. And when I'm giving a breathing treatment and you get to have a conversation with someone, and there's been times that you can tell someone's having a really rough day. They're really upset that they have to be in the hospital. They're not feeling well. They're really down, and it's just nice to see that just your few minutes to have a conversation with them, and don't treat them like a patient, but actually conversate with them like a person. It really does make their day. And of course, I love that we get to save lives. With respiratory, Our number one thing is the airway, and you know that makes a difference. At Cox-Monett, I get to go down to the ER and take care of our emergent patients. In med-surg, I get to take care of our chronic lung patients, and then up in OB, we resuscitate newborns that come out and are having a hard time getting adjusted to being outside the womb. So what would my dislike be about respiratory? I have to say it's sputum. And of course, in respiratory, snot is what we do. So I just have to get used to that and move on and deal with it. And I'm sure as you get into the health field, there'll be something that will just be, ooh, gross. And you just do it. It's your job. In all honesty, though, one thing that I don't like is that in the healthcare field, you can't save everybody. And there have been some times where you're watching someone's loved one pass, and it is difficult. You take that with you. And just in the last few years, I watch a mom and a daughter sit in the ER and watch their son not make it. Or I see my best friend come in and we have to resuscitate and he doesn't make it. So you do sometimes take that home with you, and really how I deal with it is I just cherish my loved ones and say some prayers. Some skills that we do as a respiratory therapist: you'll be working with oxygen, and we'll be going over some oxygen equipment and tanks here soon. We give inhaled medications, and I will say the number one medicine that we give all the time is albuterol. I really wish I had the patent on it because it's been around a long time and it's saved a lot of lives. You have people with asthma that take albuterol, and what that's doing is when the lungs are spasming, there's muscle that surround our little airways and they close off. So that albuterol gets in and it relaxes those lungs and lets you be able to get a breath in. We also suction, mechanical ventilation, and then our code blues. I also do arterial blood gases, and this is a little funny story. I have to say, when I was in your shoes, I took this class when I went to Monett High School. And I followed a respiratory therapist, and I thought, this is really neat. This might be a profession that I could do. I either wanted to be a nurse, or I wanted to be a respiratory therapist, or I wanted to be a physical therapist. Well, I don't know what I was thinking. I decided to go into respiratory, and we sit down for a lab day, and my instructor pulls out a needle and says, guess what? Today we learned how to do arterial blood gases. And I really did look at my instructor and say, you mean I have to stick someone with a needle? I didn't know respiratory therapists did that. He really thought I was funny. So some personality traits that you really need to think about when you're wanting to get into healthcare. This really goes for anybody. You need to have empathy, compassion. You need to be a multitasker, and trust me, you will multitask. You'll even have to decide what task is more important than the other task. Very observant, because you will do many, many, many assessments through the day on all your patients. And a critical thinker. So just some things to think about when you're going into the health field and what you'll need to have in your soul when you go and you do your profession. As far as a salary or an hourly wage, I did look it up, and this can vary throughout the United States, and depending on cost of living, this can vary. But here in the Southwest Missouri area, a respiratory therapist, an hourly wage would be $20 to $33 an hour. And then as maybe a gross income for the year, you could probably pull in $45,000 to $60,000 a year. And of course you get to that higher mark when you've worked years and you've worked your way up your career ladder. All right, so let's get into the basic well, wait, before we go on to that, I do want to say there are 3 programs in the area, in the Southwest Missouri area. You can get your degree at MSSU, MSU, and OTC. Those 3 around here do offer a respiratory program. If you go to MSSU or MSU, you're able to go 2 paths. You can just get your associate's degree, which is about 2 years. Now for me, it was 2 plus 1 year, so total of 3, because there are some basic credits that you have to get, and then you apply to the respiratory program. And then OTC is just a 2-year, 2.5-year degree. You wouldn't be able to go on and get your bachelor's. So if you want a bachelor's degree, then you'd probably want to go to a university to be able to do that. All right, now we're going to talk a little bit about oxygen therapy, and I'll be walking over and showing some equipment, but oxygen, believe it or not, is a drug. You know, we breathe it. We all breathe in oxygen, but in a hospice setting, you have to have a doctor's order for oxygen. Oxygen relieves hypoxia. It decreases the work of breathing, and it decreases the work of the heart. And then Ashley's passing around. This is just FYI, you can take this. This is some of the equipment we'll cover, but this really gives you a good background of oxygen therapy. And as CNAs, if you do go on to do that, you're going to need to know a little bit about that. You'll be doing vital signs. You'll be checking your patient's pulse ox. You'll be looking at the flow meter to make sure, are they on oxygen or not? And if you have to walk a patient or transport a patient, you might have to be the one that sets them up on the O2 tank so they can do that. So that's why we'll cover that a little bit. All right, so coming over here, and I think this works. Can you still hear me? Okay. As far as our oxygen equipment goes, you have just your typical nasal cannula. So if somebody needs oxygen, it's typical that they need just a few liters. We have adult sizes, and we do have little baby and pediatric sizes. And then if you're really sick, you may need a lot of oxygen. So you'll have something called a non-rebreather. And so oxygen fills up into the bag. You want the bag to be inflated, and that needs to stay inflated, and it gives them a higher oxygen percent. And then just some other equipment that you might see a patient have to do in the room is the nebulizer treatments. This is that inhaled medicine that I was telling you about. We would put the medicine in a little canister. It hooks up to air or oxygen, and it makes that a very fine mist. So that way the patients can breathe that into their lungs. One thing we also do, a big part of what we do, is airway clearance. And what that is if a patient has pneumonia or they have an illness going on where they have a lot of mucus, that sputum, that they have to cough up, then we need to clear that out. And if they're having a difficult time doing that, then we have a device called an acapella. It vibrates, and when they're blowing in, it just helps to move that vibration down into the lungs and help work that mucus up. So I can show that to you. It's not too hard. We have them put their mouth on the mouthpiece. They need to take a nice breath in, and then they're going to blow out. So it looks like this. And we would have them do 2 to 3 sets of 10 to 15. I will say respiratory therapists loved this invention because the old way of doing chest PT was to actually move your patient into different positions and sit there for 5 minutes clapping on their chest. The whole treatment took probably about 30 minutes. So, I mean, we can still do that because some people like that old school way, but this really does take the place of it. It does a good job. So we talked about with oxygen therapy, if you have to hook up an O2 tank, this is what we call an E-cylinder. if a patient's on 2 liters, and I'm just throwing that out there, that's pretty typical, 2 liters, this tank would last 4 hours. And of course, if you go up on that liter flow, then you're taking that time down. So 2 liters, you're gonna have about four hours of oxygen in here, plenty of time if you're wanting to walk up and down the hall or you're going to a quick x-ray downstairs. All tanks come with just this cover over it so you know it's full. So we take that off. And it may be hard to see, but on the side here we've got holes. And that's where we're going to fit a regulator. And what a regulator is, it's what's going to dial in and give the patient the oxygen. So on the regulator, just throw that down there. And again, I know you can't totally see this, but we have 2 plates, basically 3 spots that you'll want to know about. We have the dial, that's going to tell you how much oxygen you have. We have the dial here on the side, and that dials in the liter flow. And then where we're going to hook up our oxygen. Now right inside, there's pins. And a regulatory board in developing with different gases, because there's oxygen, there's helium, there's CO2. They really developed where this regulator only goes on oxygen. So that's a good thing, because you know, if somebody tried to put it on a helium canister, it's not going to work. So that's a really good regulation to have. So you just kind of slide that down, lift it up, line everything up. And then we have our tank wrench. And then of course you always have to play with it to get it really tight so you don't have any leak. Let's try that again. Okay. Let's see. All right. So then we would dial in our oxygen, and then you can hook up either your cannula and then you're ready to put this on your patient. And then I wanted to demonstrate that high flow to you, the big mask with the bag, and what I was talking about as far as being able to inflate the bag, and that's very important. So we use this mask for emergencies, somebody that's not oxygenating well, and maybe before we need to intubate or do something like that. So we will put this on them to really hyper-oxygenate them and give them 100%. So there's that bag and how it inflates, but you need that high flow. All right. Now, as far as tank safety, you wouldn't want to just carry this around. If you drop this and it cracks, you now have a missile, and it will take something out. Either you put a hole in the wall. So that's why tank safety is very important. When transporting an e-cylinder, you want to have it in a holder, or with a bed, there's usually a little holder underneath the bed that slides the tank in. but you want to really be aware of that it's not going to roll off and bust. Okay, let me turn this off. Oh, where am I going? And it's really easy to get backwards on what you have opened and what you don't. So you just want to turn it off, and then the rest of the oxygen will bleed out of the regulator. Now, you know, I don't know, you may experience this if you were a CNA in a critical area. I wanted to bring a ventilator and show it to you. And of course, all ventilators are all different, but the goal is the same. This machine is going to generate flow, and it's going to give a patient a breath and let them breathe. Of course, when they're on a ventilator, they're going to need sedated. So that's why if you've ever been in an ICU, they're not awake, they're not up, they're not talking to you. If they're up and talking to you, then more than likely we could probably take them off the ventilator. So they're going to be sedated. They're going to be hooked up to a lot of medications. They're going to have equipment. We have an ET tube that goes into their mouth and down into their lungs, and we secure that, and then that's how they're going to get their breath. So I'm going to turn this on. So this is the patient's, we'll pretend this is your patient, this is your lungs. And so we put them on some settings, and based on what their lungs are doing, we may have to adjust settings. We can have a fast respiratory rate, a slow respiratory rate. We can have a bigger volume or a less volume, but we're controlling their breathing. So this is where that critical thinking, that multitask, that observant trait comes in. There's a lot involved in providing a patient with mechanical ventilation. And it's not just respiratory. You're going to work with nurses, doctors, dietitians, cardiac, kidney doctors. All of that is affected when you're on a ventilator. So just something to know and think about. And of course we have alarms. It's just telling me that the patient's apneic, which they're not taking extra breaths. This is just the mode it's set on. But so that was just a little, yes. So that's just something extra for you to see. Now just basic going on the med-surg floor, you're not going to see this. If someone's on a ventilator, they're in a specialized unit. Any questions so far? All right. Well, I want to finish up before I talk about COVID-19. Just a couple of stories. First of all, I can honestly say I'm probably the only respiratory therapist in our area that's ever broken her nose with a flow meter. On night shift, I was trying to pull a flow meter out of the wall, and I've got one here to show you. And it just didn't want to come out of the wall. And so I'm giving it a little tug, trying to get it out. Tug a little more, it's not coming out. Finally, I'm like, gosh darn it, I need to pull this out. So I really give it a tug, and I'm short. So I'm nose level with my fist and the flow meter. And the wall decided to release it, and with the force, I broke my nose. So that was really fun. My supervisor had to take me to the emergency room. I was bleeding, you know. So there is some hazards, I think, that you'll find in a healthcare job, and luckily I don't think that happens too often, that an RT breaks her nose with a flow meter. And then lastly, I have to say, working at Children's Hospital, I got to meet a surgeon called Dr. Nuss, and I don't know if you've ever heard of a pectus excavatum, but it's where your chest is sunken in. So, and it can be very defined, or it can be very little. But he developed something called the Nuss procedure. And what that was is if you could get a child at a younger age where their rib cage is not fully developed, their bones, their cartilage, and all of that is still developing, he inserted a titanium rod into the chest, and then that child would wear that for a few years, for a time. And then that titanium rod would actually pop out the chest, and then hopefully that would harden in that spot. And then when they took the rod out, then their chest is back and expanded and not sunken in. It actually looks like a normal chest. So I thought that was pretty cool. I mean, it's just amazing how innovation can help somebody and take care of something, you know, like that. Now, of course, the argument was, well, are you doing this for cosmetic or are you doing this for health reasons? And it's health reasons in the sense that we would take care of the ones that it was really severe and it would cut off their lung function. So something like a titanium rod going into the chest actually, you know, made a difference for many kids. So I thought that was something pretty cool. I'm going to end with just a little bit about COVID-19 and, you know, bless you kids. I can't imagine what you've been through this year. It's been challenging. It's been challenging everywhere. And in the health field, you know, I won't lie, it was a little scary when it first hit and we're trying to figure out what this is, what we're going to do, how we're going to treat it. So back in March, April, there was a lot of changes and troubleshooting and thinking to come up with how we're going to handle this when it hits. And one of the things is the PPE. You know, that's the big thing to keep you safe. Now that we've kind of been through all this, I can say standing here now, not like what I was a few months ago, I'm less afraid of it. I really am, because I feel like if you put your PPE on, you do the right things to protect you in the hospital, then you're going to be okay taking care of these patients. But you have to be very cautious. So that's the important thing. Everybody working together, everybody communicating to keep everybody safe. As a respiratory therapist, we certainly are on the front line, because if these patients get really, really sick, then they're going on a ventilator. And that's what we have to do. Their lungs are getting a hit. They're getting destroyed, basically. The cells are attacking the lungs. And to help this patient get through and buy them time, they have to go on a ventilator. So that's where that machine comes into play. And of course, I already talked about all that would be involved in the care of that person. One thing that's really made a difference in our patients is that at South, we've been told they are giving plasma. So that convalescent plasma, along with steroids and then the drug remdesivir, those three in combination have really reduced the length of stay for some of these people. And if we can catch it before it gets to the point where they're on a vent, it can maybe turn them around. But it's also saved lives. We currently have a patient that I would say he's a walking testimony of those therapies, because he was very ill and on a ventilator, and he got that treatment there, and he's off the ventilator. Hopefully he'll get to go home and have somewhat of a normal life again. I won't say that he's going to have a completely normal life, because patients are telling me, you know, months out of having COVID, that they have shortness of breath still. So it's going to take a while for them to get back to their normal. I'm going to demonstrate putting on this PPE. It's really kind of not funny a little bit. I've had to wear it a few times in the ER. We bring patients in, they go into what's called a negative pressure room, and what that does is it allows the flow to be taken out of the room. So a lot of what we do in the ER, it produces a lot of aerosol. So we want to try to limit the amount of aerosol in the room, so we use a negative pressure room, and then again, putting on the PPE. I'm going to take my glasses off. So we have what's called an N95 mask or a respirator, but it's a more efficient mask when going in to take care of a COVID patient. So we put that on first, and of course, wash your hands. You'll probably have gloves on. And then we're going to put the mask on. And you have to be fitted for this. So working in the healthcare field, you'll work with occupational health, and they'll actually fit you to your size. So this is my size, and we just make sure it's all nice and secure. We kind of blow out to make sure there is a seal and there's nothing leaking. And you want to cover up your hair. And that's really fun for us that have long hair. I usually have to have somebody just do a check for me and make sure that I have it all in there. Hopefully I can do this without falling. So if I have to lean up against the wall, I might. But this is our bunny suit. Okay, and let me just make sure here. There's my other leg. This is our practice PPE. That was one thing that we had to do when COVID started. You know, you want to make sure you guys put this on right and you take it off right. And really taking it off is even more important because it's contaminated at that point. So our whole respiratory department had this up there, and we're trying to put it on. You can put goggles on or you can leave them off. I just always, I don't know, I feel a little safer having goggles, and then we wear a face shield. All right, so now I'm ready to go in a room with a COVID patient. And again, probably have some gloves on, definitely have some gloves on. Now at the hospital, we have to be in this for whatever length of time we're going to be in that room. And I already have had an experience where we had to resuscitate, code blue, a patient in this gear for about an hour or more. So this gets a little sweaty. You're sweating inside, it's a sauna. And when you come out, you're going to be drenched. But this is just to keep us safe. So just imagine that. This keeps you safe, and it's pretty massive to have to wear for quite a while. We also have a person, so when we come out of the room, there is a coworker that's standing there helping us, because you know, you want to take this off in the right way and keep yourself safe. So they usually are here to help us take this off. It's called doffing. So I donned, and then now I would come out and I would doff. And so of course you want to wash your hands, or you want to get rid of your gloves that you've worn in there. We've actually washed our gloves. We have done that to conserve on gloves. So you might see nurses washing their gloves instead of taking them off. But you can take them off, wash your hands. And then you would want to put on another pair of gloves. And then in the room, you're taking all this off. You would take your bunny suit off, and you want to just kind of work it down. Try to not touch the front of it as much as you can. So you have to be a little acrobatic here. And of course you're pulling out the clean side that was next to you. Rolling it down. And then of course you want to just roll it up away from you. That would go in the trash. Wash your hands. And then a lot of times we're having to reuse the face shield. So we would need to take this off and wipe it down. So we have a lot of purple wipes that we use. But you again always want to grab from the part that's not really been around the patient a whole lot. So grab from the sides or the back. We lay that down. We have our purple wipes. We're cleaning that. Wash your hands. Take your goggles off. Clean them. Wash your hands. Take your bonnet off. Throw that away. Wash your hands. You're washing your hands a lot because you're touching everything that's potentially contaminated. And then a lot of times we're reusing the N95s. You know, we're getting better though. We do have a really good supply of them, but we still try not to be wasteful because this is a very important mask. So what we would do is, again, just being very careful. Grab from the back. Take this off, and you would either, we have an area where everybody has their mask and we keep it there, or you can put it in a paper bag, but it's there so we can grab it and reuse it again. Now, if it gets really wet and soiled, then we would just pitch it. But if I'm just going into a room for just a very brief time, then I don't need to throw it away. I can really reuse it. Just, you're going to have to be careful storing it. And then when you get it back out to use it, again, you're washing your hands a lot as you're putting it on and adjusting it. So, all right. Whew. Any questions? Well, I wish you all the greatest this year, and I'm hoping we'll see you back at the hospital, and we'll see how it goes. But you know, we certainly think about all you guys all the time. We know we're all in this together trying to get through this, and we will. I definitely have hope that we will.
Thank you.
You're welcome.